All right. Hello, everybody. Um, we are doing a recorded ASCP 2024 annual meeting talk on the building of competency-based evaluations of pathology and laboratory medicine residents. I'd like to introduce us as our faculty. We have Dr. Henry Rinder, who is a professor of laboratory medicine and hematology at Yale University School of Medicine. In the Department of Laboratory Medicine, he's our vice chair for clinical affairs, the director of our hematology laboratory, the associate director of our residency program, and he's one of our ASCP past presidents. And I'm Alexa Sidden. I'm a professor of lab medicine and pathology also at Yale University, and I'm the medical director of the molecular diagnostics laboratory and the clinical flow cytometry laboratory. I also run our hematopathology fellowship. And so important to note for this lecture, Dr. Rinder and I both have a very heme-oriented swing of things. So our lecture is going to have a hematology twist to it that could be reapplied to any of our subspecialties. The outline of our talk, we're going to start with going over some of the current concepts in pathology and laboratory medical education that we're all using. I'm going to share a few novel ways to enhance our learning. And then Dr. Rinder is going to lead us off and give us an overview of competency-based evaluation, both in hematopathology and hemostasis, and then we'll wrap it up. I have no financial disclosures. Dr. Rinder has a couple of companies let you read on the screen. So with our current teaching and learning models in pathology, the ACGME has given us 6 core competencies, and this is throughout all of medical education. And the 6 core competencies are patient care, where the general idea is that residents have to be able to provide patient care that is appropriate and effective for the treatment of our patients' health problems and the promotion of their health. We have medical knowledge, where the residents have to demonstrate some level of knowledge of evolving medical practice and clinical care. We have interpersonal and communication skills. This is kind of a big one. The residents have to really demonstrate interpersonal skills, communication skills, and that's with multiple different people. So we have patients, families, we interact with the public very frequently. We have clinical care teams. We sometimes provide consultations. We have professionalisms, which is a very important one. This is providing respect for others, compassion. This is responsiveness to the patient needs, accountability. The 5th core competency that the ACGME provides is practice-based learning and improvement. So this is the residents have to demonstrate the ability to investigate and evaluate care of patients and to assimilate evidence to providing patient care. And they also have to develop some skills and habits to meet some of the goals. I'm crib noting what the ACGME actually puts into writing for all of these. For the practice-based learning and improvement, our residents need to identify strengths and deficiencies of their own knowledge. They need to set their own improvement goals. They need to do some quality improvement measures. Use information technology, which is rapidly being integrated into pathology and lab medicine. And then the last competency is our systems-based practice. And so this is where our residents have to demonstrate an awareness and responsiveness to a larger picture within a health system. And so when we have these different ACGME provided competencies, we can then reapply them to our own specialties. So if we think about them in the context of pathology and lab medicine, this is where our residents are actually generating pathology reports, they're grossing the tissues, performing autopsies. When they're on lab medicine call, they're providing consultations, they're doing frozen sections. So this is our actual patient care. Medical knowledge as it applies to pathology is understanding the physiologic processes and disease mechanisms. They're showing that they understand histology and what organs, what normal and abnormal organs look like under the microscope for those tissues. They're showing that they can use all of the medical resources that we have available today. When we apply pathology and lab medicine to interpersonal and communication skills, there we're talking about our residents discussing patients with our clinical teams, so other attendings, other residents, and different services. They're presenting at tumor boards. So they're doing multidisciplinary care for our patients. Professionalism, again, is an important one. So this is where we have our residents take accountability and responsibility for their actions. They should have mature interactions with colleagues, especially from other disciplinary teams. And they're also assessing their own personal well-being and taking accountability for that. Practice-based learning and improvement, our pathology residents are using, again, evidence-based medicine and applying it to our patients. They're contributing to scholarly activities, whether that be doing academic research, publishing case reports, teaching, and then they're also seeking feedback to improve their patient care, which I think is a really important one when you're assessing how you're doing in a learning environment. And finally, our systems-based practice. Our residents are participating in quality improvement and or patient safety events. Maybe they're collecting appropriate data from multiple different sources from the medical record to render accurate diagnoses. Our residents are understanding laboratory accreditation and test validation. I think that's something that I struggled with as a resident. I think that was something you really have to seek out. And now we're finding new mechanisms to teach this and to have our residents learn it. So these are our core competencies. And I'd like to go over some ways that we use different types of educational activities outside of lecture-based teaching for our trainees. One of the things that I've implemented in hematopathology is simulation-based learning. This doesn't apply to all specialties, but we made it work for HemePath. So our residents and fellows are expected to participate in bone marrow biopsy procedures, especially the fellows. It's one of the things that we sign off on for our fellows to participate in the HemePath boards. Our residents and fellows gave feedback asking for some sort of practice or introduction to this ahead of seeing our patients and having that be the first interaction they have, having that big trocar needle. And so we found online that there was a biopsy simulator that we could purchase. So we did. And it's kind of like a CPR dummy, but for bone marrow biopsies. And we collaborated with our hematology colleagues to teach bone marrow biopsy procedures. So what we did was we had a bone marrow biopsy clinic, and this has become a yearly activity. We do this with medical students. We do this with residents, with HemePath fellows. And so you can see we've got this bone marrow biopsy trainer. It actually has plastic hip bones in it that are replaceable, and you use the bone marrow biopsy needle to actually take a biopsy from the patients. And so here we have a couple of our hematologists that are teaching some medical students and residents how to actually do the bone marrow biopsy procedure prior to going and seeing a patient. And so we took the needle, and you can actually take you can see on the right sided picture, you actually get a core of bone tissue to come out of the biopsy trainer. It's gotten really good reviews. The students really like it, and it makes everybody a little bit more comfortable. It also gives our heme-onc colleagues a good way, they get to work with us, and we enjoy working with them. They get to teach us how to do these bone marrow biopsies. One of the other things that we use for interactive education, the Society for Hematopathology has spent a lot of time creating interactive modules on various topics. They built these for a variety of learners, the residents, the hematopathology fellows. I've started asking our hem-onc fellows to learn from these interactive modules. If you go to the website, which I've given a screenshot of on the right, there are numerous different modules where if you click on them, they go through about 30 minutes to an hour of learning. It's interactive. You have to turn up your volume. You can hear the cases being talked through, and there are questions that you can answer throughout each case study. They are all on different topics, but there are some very primary ones, just learning to evaluate a peripheral blood smear or to look at a bone marrow biopsy. They're really one wonderful resource that I recommend for people at all levels of hematopathology training. One of the other interactive education modules that we like is the Training Residents in Genomics, or TRIG online modules. This was a multidisciplinary instruction tool with many of our pathology organizations, some of the genomics organizations, and it is intended for, again, different levels of learners. So there's modules that are more trained, more directed towards residents and fellows, and then there's undergraduate resources. This is you can find this on the ASCP website, but it's hosted by, again, several of our different pathology organizations, and I think this is a wonderful resource to share. And HemePath has so much molecular in it that I always recommend our trainees check it out. In pathology and lab medicine, one of the things that we hear is that lab management is one of those nebulous topics that is hard. It's hard to train. It's hard to teach that. Sometimes you just have to do it and pull in the residents when something comes up from a management perspective. But now the ASCP has produced this course called Lab Management University, which is it's an online available course that you can purchase, and I think it has been given to our residents that we've used it pretty extensively, and this is a really nice, again, self-directed type of tool that our residents have given good feedback about. And for our HemePath fellows, you can read more and more about this concept called entrustable professional activities, or EPA. And EPA is a unit of professional practice. This was we've been talking about these for the past 10 or 20 years now. However, I think we're really integrating them into practice more and more. So we define them as tasks or responsibilities to be entrusted to the unsupervised education of a trainee once he or she has attained a sufficient level of competence. And so this allows for discrete tasks that in hematopathology, we expect our fellows to be able to accomplish every day. And this gives us the ability as attendings to give the fellows individual feedback, and we try to do it in real time. The Society for Hemopath, again, has published 10 EPAs. They had a working group that identified 10 sort of large-scale tasks that hemopath fellows should be able to do. On the left here, I have the list of the tasks. For example, selection of the diagnostic tests for a bone marrow biopsy sample, select a flow immunophenotyping panel, and compose an interpretive report for flow cytometry. There's an EPA on hematology and coagulation interpretation and consultation. And then when you read the individual EPA for one of those larger categories, it breaks it down into what exact skills are necessary to accomplish that task, the knowledge areas, some example scenarios, and which of the hemopath milestones each of these tasks touches on. So it's these are great resources to integrate into training. And there are EPAs up and coming for a lot of the different areas in pathology. And so now I'll turn it over to Dr. Rinder to talk about competency-based evaluations.
Thanks, Alexa. One thing I'll say is that, the Society for Hemopath has really given us a great basis for looking at competency-based evaluations and linking that with entrustable professional activities. So keep that in mind as we go through some of our examples here. And remember, these examples are purely meant to be illustrations of, one possible method of handling competency-based evaluations, and are really meant to be a starting point for discussion. Dr. Siddon's controlling the PowerPoint, so we may have a little bit of a lag as she hits the space bar and I talk, but that's okay. So let's see, or do we go back to that first slide though? So my goals are to talk a little bit about rationale, evaluate some examples in hemostasis testing, suggest how CBE inform graduated responsibilities, and show you why CBE may be a justification for EPAs. All right. So the rationale for CBE of hemostasis testing. Right now, multiple choice questions are what we mostly use for medical knowledge, but that doesn't really take you beyond medical knowledge as one of the competencies. Not all academic medical centers will have experts in hemostasis testing to educate the trainees and to have those trainees demonstrate judgment in signing out actual cases. So CBE provides an opportunity for multi-step cases, multi-competency inclusion. And if we make it a free-form CBE where there's no multiple choice, it can actually emulate real cases and interpretive management decisions. So some CBE examples in hemostasis testing. I'm going to give you a case, part one. You're the director of a hemostasis laboratory at a tertiary medical center. You're responsible for assuring quality testing, determining reflex assays, consulting with ordering providers, and of course, final test interpretation and recommendations. A patient's sample is received from Tiny Hospital, a 30-bed institution that is 45 minutes away. PT-INR and PTT are ordered, and there's an inclusion of 2 additional blue top tubes, just in case more testing is required. The PT is 11.5 seconds, which, as you can see, is within the normal reference range, as is the INR at 1.1, but the PTT is prolonged at 47 seconds, well above the upper limit of 30.2 seconds of the reference range. So here's where we would start to ask our resident or fellow to give us their plans and actions in a free-form way to decide how to take care of this patient, how to get answers. So we would say, what are your initial plans and actions? Possible responses from the trainee would follow in italics, giving some examples. So the trainee might say, I'd like to determine from the laboratory whether the samples that were received were in acceptable condition for testing. They might ask, how much additional sample do we have for testing? They may desire to plan to call Tiny Hospital to speak to the provider and obtain both a history and the rationale for testing. Finally, if they want to get down to it, they may say, if adequate samples are present and we can do these tests, let's perform a PTT mixing study. Now, our evaluation of the trainees' responses, so the trainee responses are here in italics, our responses might be as follows. So they've asked to determine from the laboratory whether the samples were in good condition and how much additional sample was present. Our reflex response would be that there's a citrate anticoagulated plasma sample. Multiple aliquots were sent frozen on dry ice and were received fully frozen. A single aliquot was thawed for the original testing of PT, PTT, INR, and all other aliquots have been stored in -70. So we're responding to their additional competency-based type questions to tell them that these samples are adequate. Now they're showing their interprofessional skills by wanting to speak to the provider for the history. So we provide them with the fact that this was a 72-year-old male, no prior history of bleeding or thrombosis. The patient noted excess bruising after splitting and carrying wood. Apparently, he works in Hansel and Gretel's forest. Evaluation in the emergency department showed multiple ecchymoses on both the torso and the upper extremities. In fact, there was concern for forearm hemorrhage with possible compartment syndrome. The tiny coag lab found a normal INR and prolonged PTT like we did, so samples were sent. And our resident wants a PTT mixing study, which we gave. At immediate mix, it decreased to 31 seconds, but after 60 minutes of incubation at 37 degrees C, the PTT prolonged back up to 45 seconds. With that information, we're asking our trainee now, okay, based on your current understanding of the case, what's your assessment and plan for additional testing or management? Here are possible responses, again in italics. Well, they've assessed that with no prior history of bleeding, clinically at least, they think this patient has a newly acquired bleeding disorder. They want to know, does the patient have thrombocytopenia? They're going to go back and recheck with the ordering provider to see if a CBC was done and what were the results. Now, they've assessed that the mixing study indicates an inhibitor that is most active after incubation, and they feel that it's consistent with targeting a specific coagulation factor, most likely factor VIII. Finally, they want to use some of those frozen aliquots to measure factor 8, 9, and 11 activity. And if those activities are abnormal, they're going to reflex to perform inhibitor assays. So now our response. They've asked about thrombocytopenia. So they're going back to the clinician for CBC results. We do that. And we find that the CBC at Tiny Hospital showed a normocytic anemia, a normal white count, and a normal platelet count at 182,000. Now, they also wanted to use frozen aliquots to measure factor 8, 9, and 11 activity, which were done, and factor 8 was 0%, very abnormal, but both factor 9 and factor 11 activities were within the normal range. So the factor 8 was the only inhibitor assay that was done, and it shows an inhibitor at 16 Bethesda units. Excuse me. All right. With this information, we go back to the resident. What's your final assessment and plan for additional testing or management? And here are possible responses from our trainee. They assess that the patient has an acquired factor VIII inhibitor. They're going to call the tiny provider to let them know the diagnosis. And they're going to sign out the interpretation as consistent with an acquired factor VIII inhibitor. This would be the final section of the competency-based evaluation, which ends on their last assessment and they're signing out of the case. But that's not the end of our evaluation here. We're going to grade the CBE and discuss this with the resident to see areas of improvement. Excuse me, to see if there are areas for improvement. Now, remember, these are free text answers with no multiple choice. So we might have in advance validated answers from the faculty to examine for any of the following. A listing of possible correct responses for each aspect, including assessment, suggested testing, interpretation of the results, and communication and management. And as you can see, this brings in multiple of the competencies as discussed by Dr. Sidden. We want to grade the correct responses in order of importance for patient care. And we want to list the responses that are either incorrect or perhaps not necessarily incorrect, but not contributory. And in those cases, we might have those detract from the grading. So again, possible examples for case one are as follows. When our resident gave initial plans and actions, here are their responses in bold. I'm sorry, in italics. And then our grading in bold. So the resident asked, were the samples in acceptable condition? This is a great question. It's key in that abnormal results, especially from outreach where samples might thaw while being transported or incorrectly prepared prior to being couriered. Those samples may give abnormal results, but are purely a pre-analytical error. They want to know if there was additional sampling for testing. Again, a great question, because if they're going to contact the ordering provider, they may actually need more samples in order to pursue ideal testing or to complete the algorithm for clinical testing. They plan to call Tiny Hospital. The clinical history should always dictate the direction of testing. So this is an excellent point by the resident for their planning. And finally, they decided to perform a PTT mixing study. Can't fault the resident here. Again, that's absolutely the first additional study to help guide subsequent laboratory evaluation. So the resident did really well here, and I would grade them pretty highly. Dr. Sidden agrees and put them at 100%. Okay, now let's go on to part two. Again, we're asking to re-show their assessment and plan for additional testing or management. Here are the responses from the trainee, and in bold is our grading. The trainee assessed that the patient has a newly acquired bleeding disorder, and we agree that's the most likely clinical scenario. Compartment syndrome could also result from thromboses. That's why the ecchymoses are so important in guiding the assessment that there was bleeding in the forearm. One could ask, did they image the forearm to rule out a thrombosis, but that's not critical. The resident here had a great catch. Does the patient have thrombocytopenia? The prolonged PTT could be completely unrelated to bleeding, and thrombocytopenia is always in the differential, especially in older patients. So a really great catch by the resident. They wanted a mixing study to be able to decide if this was an inhibitor or a factor deficiency, and they did a good job of evaluating that. This would be the classic presentation of a factor VIII inhibitor with a near normal immediate mix and then prolongation after 60 minutes of incubation. They wanted frozen aliquots to measure multiple activities. Certainly agree with the factor VIII activity, as that's the most likely pathology. The resident could have opted to hold factor IX or 11 testing until the factor VIII result was complete. But with deficiency of VIII, they wanted to measure the inhibitor, and we have to know the strength of that as measured by Bethesda units. So again, very solid responses by the resident here as part of their free-form competency. So we'll see what Dr. Siddon graded them as. 95%. Maybe I'm being a little bit picky about factor IX and 11. Dr. Siddon, I think I'm going to go with her grading. I'm all for that. Finally, on part 3, again, here's their assessment for additional testing or management. The responses are as follows. They assess that the patient has an acquired factor VIII inhibitor. Completely agree. I might go a little further to note that it's a strong inhibitor, and therefore that might dictate therapy and management. They want to call the provider to let them know. Absolutely. But I think they might even go a little further to ensure that the provider actually understands the consequences of a strong inhibitor and the needed management. This is now part of systems-based practice. The tiny hospital may not have the appropriate bypassing agents for therapy in their pharmacy or blood bank. So the patient may require transfer to your institution, in which case you're now the natural communicator for subsequent care. And finally, when they sign out the interpretation, I completely agree. The only thing I might do is add in that it's a strong inhibitor, and of course, document the nature of your discussion with the provider. After all, they might not agree with your recommendations, and it's important to have that as part of your thing. Oh, Dr. Siddon gave him only an 80% on this one. Okay, I think I'd agree with that. Still, very, very good assessment by our trainee in all areas of competency. So this brings up principles for discussion. We like the breakpoints to be open-ended to allow for what we call ADR, assessment, differential diagnosis, and recommendations, whether they're diagnostic or therapeutic. The breakpoints in our example are purely meant for snapshots. They're not meant for the trainee to see all at once. That way, this patient case can evolve as if it's in real time. The reference answers from the attendings have to be written in advance. This can't be personal. It can't be serendipity. You've got to have these answers built. And the reference answers should have highlights for grading, keywords, key phrases, differential diagnosis, such that this is all a reasonable approach to a discussion with your resident. Other principles for grading and scoring. There are many ways to approach this. You could have the percentage of key highlights, holistically as a logical progression of ADR, comprehension of the cumulative results such that the resident rapidly gets to an answer. And finally, we evaluate ADRs that weren't included in the reference. Some might be irrelevant. There might be examples that don't fit the logistical progression, but they also might be very relevant possible answers that actually should be included in the reference. For example, we can now improve our CBE based on trainee feedback, such as asking for thrombocytopenia in the prior case. building a cohort of CBE in areas of expertise so the prolonged PTT workup in a separate example could go in a completely different direction. A 72-year-old male with no prior history of bleeding or clotting, but now he has a past medical history of a TERP and he's admitted with gross hematuria. The patient is scheduled for cystoscopy and surgery is calling for blood products. We've never had this happen before. The PTT is prolonged with factor activity levels as follows. Factor 8 is 0. Factor 9 is 3%. Factor 11 is 2%. Oh my God, they have 3 congenital deficiencies. The trainee is brought into the case at this point for ADRs at several breakpoints, yada, yada, yada. The patient is found to have a strong lupus anticoagulant and actually doesn't have a bleeding disorder. So we show these as examples to go in all different directions, meant to provoke discussion and a good interaction of the trainee with their mentor to go over competency-based evaluations. Other ways to consider in using CBE, and I'm going to thank Stephen Black Schaefer for giving us this idea based on slides he showed. So over time in training, patients acquire medical knowledge. And this is not my own personal acquisition of medical knowledge. Thank you. But then over time, they also acquire medical judgment. And some residents, not me, are shown here in red where their medical judgment is much faster, whereas patients, some residents more like me, took a longer time in purple to acquire medical judgment. But the aspect here is that the inflection points for knowledge crossing with judgment can help determine how quickly the resident can progress in their training, to assign them increased graduated responsibility, and to basically say that they've attained certain EPAs. Examples. Here's a case for a more senior resident. We'll go through the same thing a little bit more quickly. You are still the director of the hemostasis laboratory at a tertiary medical center. An outreach coagulation order set has the following results. PT is normal at 11.1, as is the INR. The PTT is very slightly prolonged, maybe 5 seconds above the reference range. The PTT mix at 0 corrects, as does the incubation at 60 minutes, but the factor 8 activity is 25%. The requisition lists the diagnosis as mild hemophilia A. The outpatient is an 81-year-old female. Let's get into it. You consult with the coagulation medical laboratory scientists. There is an additional sample frozen. You call the provider who ordered the testing, but they are unavailable. But you leave your number for callback. What are your initial assessment plans and actions? And again, we'll go through the same thing. Italics are the responses from the trainee as follows. They're thinking it's unusual for an 81-year-old female to have a new diagnosis of mild hemophilia A. So they want to add on reflex testing for von Willebrand antigen and activity. Maybe a factor 8 has developed, but it doesn't seem strong enough to affect the mixing study. So the resident also wants to add in an inhibitor titer. And again, they're going to try again to speak with the provider. They are not daunted by the fact that they weren't available at the first call. Here are our responses to the questions put forward by the trainee. They want to add on reflex testing for von Willebrand studies. We do that and we find that the antigen is 89% in the normal range, but von Willebrand activity is markedly decreased and the ratio of activity to antigen is 0.30. They also wanted an inhibitor titer, but we saw that the mixing study completely corrects, indicative of factor deficiency. So we're not going to give them an inhibitor titer. They try again to speak to the provider. The provider is now available. What are your questions for them? Here are possible responses from the trainee in italics again. Excuse me. The von Willebrand factor studies are consistent with type 2 von Willebrand disease. I want to ask the provider about a prior bleeding history and also whether they have any underlying conditions that are associated with type 2 von Willebrand disease. For example, monoclonal gammopathy of uncertain significance, myeloproliferative neoplasms, and or aortic stenosis. The resident wants to hold off on interpretation as they plan to order additional testing, including a von Willebrand Multimer assay and a factor VIII binding assay to rule out von Willebrand Normandy. We go to our grading. So they wanted to ask the provider about underlying conditions. Let's see what the provider says. Even though he's in a rush, he tells you that the patient had no prior bleeding and has already been sent to your hospital for a cardiology evaluation because of suspected severe aortic stenosis. In fact, 2 minutes before, you've been called by the hematology lab to come up and evaluate the blood smear. Now, they want additional testing, including the Multimer assay. The low von Willebrand factor ratio is entirely consistent with type 2 von Willebrand disease, and Multimer testing is indicated. On the other hand, von Willebrand Normandy is not a type 2 pattern and usually has von Willebrand factor values in the normal range. So we're not going to give this to the resident. Instead, the Multimer testing, as shown on the right, shows a normal pattern on the left and the patient on the right, where you can see high molecular weight multimers at the bottom of the screen are absent or decreased. And on the left, you can see the smear where the asterisks show multiple schistocytes. So in our next slide evaluation, the resident is able to look at these and give the following assessments. On the smear, they see schistocytes, no question. On the Multimer pattern, they see that it's type 2 von Willebrand with loss of high and intermediate molecular weight forms. Their final smear interpretation is that there is microangiopathy in the setting of aortic stenosis. And their final coagulation sign out is it's consistent with acquired type 2 von Willebrand disease in the setting of aortic stenosis. Great job by the resident. Now let's go back to Dr. Sidden for a similar type of CBE in hematopathology.
Those are really great cases. I don't know if I would have done as well as the resident. So if we wanted to apply this into a little bit more hematopathology and move away from hemostasis, we could come up with all sorts of examples. So for our case, we're going to switch over from being a laboratory specialist and become a surgical pathologist at a local community hospital. When on your sign out day, the PA calls you into the gross room to assess a lymph node. You go to the gross room and read the clinical history that's provided, which is a 54-year-old female with left axillary lymphadenopathy. Same idea. What are your initial plans and actions? How do you want to handle this case? So a resident might put in that they want to submit the lymph node entirely for histologic examination. They might say they want to review the pathology system to see if the patient has any other pathology specimens. They might want to check the patient's CBC. And maybe they want to, instead of submitting it entirely for histologic examination, save a piece of lymph node for flow cytometry and or cytogenetics and molecular studies, and then submit the rest that's left over after that. So if we go through the different responses, if somebody said that they just want to submit the lymph node entirely, we might have the CBE respond to see the next slide for for the histology will provide that. If somebody said, review the pathology system to see if the patient has any other pathology specimens, then we might learn that the patient had a right breast lumpectomy specimen 2 years ago with invasive ductal carcinoma at a little less than a centimeter. If the resident chooses to review the patient's CBC, they might learn that the patient has a mild leukocytosis of about 14.8 with normal hemoglobin and normal platelets. On the differential, we might learn that the lymphocyte count is elevated at 62% of the diff. And same idea, if the resident had save a piece of lymph node for ancillary studies, then we'll skip ahead and see the histology in the next part of the CBE. So then if we are given a couple of histologic images, we might have a low power view of that lymph node and then a higher power view of that lymph node. Just for the non-hematopathologists, we're looking at effacement of a lymph node with small cells, no germinal centers. So we're seeing sheets of lymphocytes, and the additional immunostains that we'd probably provide for a resident are CD20 and CD3. We'd move on to CD5 and cyclin D1, LEF1, and our proliferation index Ki67, which looks very low for this patient. And so if we want to know how do you interpret those histologic images, somebody might say, what does the flow cytometry of that tissue show? And the flow cytometry might show a monoclonal population of B cells that are 19, 20, and 5 that corroborates the immunohistochemistry. We have some additional markers, and we're told that there's kappa light chain restriction. Follow-up testing on peripheral blood, if that was requested, might show flow cytometry of the blood showing 53% B cells that have that same immunophenotype as on the tissue. And the cytogenetics and molecular studies, if that was requested, could show a deletion 17p, but no TP53 mutation. So based on your overall understanding of this case as a whole, what is your final assessment of the case? So some possible responses from a trainee are that this patient has chronic lymphocytic leukemia, small lymphocytic lymphoma with tissue and blood involvement. They might make the assessment that there's no evidence of metastatic carcinoma, and maybe they would know that that 17p deletion is a poor prognostic indicator in CLL. So in this final section of the CBE, we would ask for these things to see what they would incorporate into signing out the case and making recommendations for our clinical team. If we want to grade this case, I would say that I totally agree that this is a CLL. I could see how a trainee might not come to the conclusion that it's CLL if they forget their immunophenotypes. Hopefully they would know that it's not mantle cell lymphoma without having a cyclin D1 positive immunostain. Maybe they would say that it's a low-grade lymphoma because that Ki67 was low. So there are varying possibilities that they could get to with some of the information, even if they don't integrate it all. I think an important part of the report would be that there's no evidence of metastatic carcinoma, especially in a case of a patient with a history of carcinoma. This was a small subtlety, but the axillary lymphadenopathy in our patient was on the other side of the patient from the breast cancer. And then cytogenetics, this is sort of a senior level question that CLLs have different prognostic markers associated with their cytogenetics. And some patients might have a P53 mutation in addition to having the deletion 17p by karyotype or FISH. And so knowing the significance of the most common cytogenetic abnormalities is important and may come with graduated responsibility and additional learning on heme path rotations. And so these are examples of ways we might integrate these CBEs into our patient learning. I'll let Dr. Rinder have a couple of wrap-up statements.
Thank you, Dr. Siddon. Yeah, again, this is just to emphasize the idea of giving residents at multiple levels the opportunity to act as an attending in a measured way, such that they ask for data, they evaluate data, they can make recommendations, and then sit down with the attending and review how they went through this. It's not meant to be anything other than a teaching tool. But to see it, but for us as faculty, to see how the residents are approaching these, how they're thinking, is helpful for us to help to make suggestions for their graded responsibility and their progression through the program. So we hope you enjoyed this. We certainly welcome any comments and suggestions. And of course, as always, we're equally interested in collaborating with other academic medical centers to examine better and new ways to optimize resident and fellow training. Our email addresses are on the screen. So if you feel like contacting us to have a discussion, we're both thrilled to have that. Thank you very much for your attention.
Thank you.